Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Anahi Perlas, an anesthesiologist and director of the Perioperative POCUS Fellowship at Toronto Western Hospital, discusses the use of gastric POCUS to guide patient care. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So we're going to talk about gastric point-of-care ultrasound today. In terms of disclosures, I do some consulting work for Fujifilm Sonosite and for Sonosim. I'm not going to be talking about their products today in particular. I would like to acknowledge as well the support of a number of professional organizations in terms of peer review grants for my work over the years, the American Society of Anesthesiologists, the Anesthesia Patient Safety Foundation, the Canadian Anesthesiology Society, the Physician Services Incorporated, which is an Ontario foundation for medical research, as well as my colleagues at the University of Toronto and the UHN for all the support they've given me. So why should we care about gastric content? You know, there's only two people in the world that care if you have eaten anything and when you have eaten: your mother and your anesthesiologist. Nobody else cares. And your anesthesiologist cares because pulmonary aspiration is still a problem in anesthesia. This particular study showed that it was a one-year audit of all the deaths in related to airway management in the United Kingdom over a 12-month period. And they found that pulmonary aspiration was actually the number one most important cause of death in the setting of airway management. And underlying that risk, they found that in many cases, there had been what they call inaccurate assessment of aspiration risk. Similarly, in the United States, this is a recent paper just within the last, 2021, a couple of years ago now. It's a close claims analysis of all the medical legal cases that have closed in the United States over the last 20 years, where the main cause for litigation was pulmonary aspiration. So they looked up all these cases. They found 115 such cases. Of course, these are only the tip of the iceberg because in order to get to medical legal litigation, it has to be a pretty devastating case. So it's not surprising that of all these cases, 57% of these cases had died and 14% resulted in permanent injury. So that's not surprising. It's just the tip of the iceberg, the more serious cases. What was surprising to me is that the emergency surgeries and elective surgeries were almost equally represented in these very serious cases. So we often, I don't know you, but for me, for sure, I had this bias that aspiration, almost never happens in elective surgeries. It's something almost exclusively of emergency operations. But I have to say, this article really made me think twice about that assumption. Because at least in these group of patients that had the worst outcomes, half of them were coming for elective operations. So imagine what a devastating thing, and many of them died. Similarly, they found that in 59% of these claims, from a medical legal point of view, they were determined to have substandard anesthetic management. Now, this is something that no anesthesiologist likes to hear. And all these data, both from the previous study that I mentioned and this one, this is first world anesthesiology. The United Kingdom, the United States, these are rich countries. They're very well-trained physicians, well-trained anesthesiologists. So the fact that they found substandard care or not accurate risk assessment, I think it just underscores the fact that our tools to define aspiration risk are very limited up until recently. If we base our assessment on clinical grounds alone, well, we don't always get it right. So, of course, we have the ASA fasting guidelines. They're very important, and there is no test that is ever going to replace the guidelines. Certainly, gastric ultrasound is not meant to replace the guidelines. It's a complement to the guidelines. So we all know them very well. I'm not going to go into details, but roughly we know that it's quite safe for patients in general to fast for 2 hours for clear fluids, 6 hours for a very light meal, or 8 hours for fatty solids. And then there's the details for pediatrics. However, the guidelines say very clearly that these apply only to healthy patients coming for elective surgeries who have the opportunity to fast and who don't have any major comorbidities or are on any fancy medications. So the guidelines have their limitations. So in clinical practice, I think as well-trained, responsible anesthesiologists that we are, I think it's quite easy to recognize the extremes of aspiration risk. On the one hand, we have those patients that have a low risk of aspiration. These are patients that are healthy with no comorbidities, no special medications, that are coming from home, that have fasted for an elective procedure, and they don't have anything wrong with their GI tract. So these subset of patients have until proven otherwise, an empty stomach. They have a very low risk of aspiration. On the other hand, I think it's quite easy to identify those at extreme risk. Patients with a bowel obstruction are perhaps the ones with the highest risk of aspiration. Bowel obstruction, acute abdomen, of different reasons, patients that are actively vomiting. I think it's quite stands to reason that they're going to have a very high risk of aspiration. In fact, they were really overly represented in that closed claims analysis. I think something like half of all patients, or 60% of the entire cohort, were patients with abdominal processes, and many of them had bowel obstructions or subacute obstructions. So these patients are clearly at very high risk. But there's a lot of patients in the middle where the risk is not so clear. These are the patients where we could say, in other words, that they have a pre-test probability of having a full stomach of 50%, where we are not really sure where we are standing clinically. And there are many situations like that. So what could be those situations? Patients with uncertain gastric content for any reason. I'm sure, I suspect it's the same situation with you. In my hospital, we have about more or less about 20 operating rooms every single day. Every day we have 1 or 2 patients at least that have eaten something in the morning. And it's hard to tell where we are standing based on clinical grounds alone. And what should we do with these patients? Should we cancel the operation? Should we proceed? Is it safe? Do we have to intubate them, do a rapid sequence? It's hard to tell sometimes based on clinical grounds alone. Of course, anything that is non-elective, again, it falls outside the guidelines. So patients that come in for urgent or emergency surgery, they may have a full stomach despite prolonged fasting. That has been long recognized. Or patients that are coming for elective operations but that have serious comorbidities, such as end-stage renal disease, severe liver disease, diabetic gastroparesis, and they may be at increased risk of a full stomach despite fasting. And more recently, of course, there's been a lot of interest in this area because of the GLP-1 agonists. So all these kinds of patients, their baseline risk is not so clear. We could say that the risk is uncertain and they are in that borderline 50-50 chances that they're going to have a full stomach. We are not so sure. So, the introduction of the GLP-1 agonists really brought this issue up to the front. In 2023, there were a number of case reports, and I think by now we have something like 15 case reports in our anesthesia literature of patients that have fasted properly, but they were taking a GLP-1 agonists, and they had a significant, really serious episode of regurgitation or aspiration under anesthesia. This was one of the first case reports. It's actually from our sister hospital here, Toronto General Hospital. Someone who was taking semaglutide for weight loss. They had fasted for 20 hours for solids, and they had fasted for 8 hours for clear fluids. So definitely prolonged fasting. Despite that, they had a severe episode of regurgitation under anesthesia. I believe in this particular case, fortunately, this happened while still intubated. So I don't think the patient ended up aspirating, but it was definitely not a pretty picture to be there. This is another case report from the United States, a patient on tirzepatide. This was published in the newsletter of the Anesthesia Patient Safety Foundation. This was a diabetic patient, and despite appropriate fasting, again, like standard more than 8 hours of fasting, this is what happened during anesthesia. There was massive regurgitation of undigested food, including solid food particles, as you can see there. So these types of case reports really raise the alert. Now, case reports are important, they're interesting, but they don't tell us what is the denominator. So it raised the alarm, but there were a lot of questions, more questions than answers. How often does this happen? Was this just a coincidence that they were on these medications, or is there some sort of causal relationship? Now, we know that these medications, GLP-1 agonists, can delay gastric emptying. It's a very well-known, established fact based on multiple studies. The effect on delay of gastric emptying seems to be more marked in the early stages of treatment, especially as the doses are being escalated. Normally, these patients start with low doses, and they do that specifically because of the GI symptoms that often accompany the beginning of treatment, such as they feel very full, they're not hungry, they feel a bit of nauseous and vomiting, and that's part of how they work. They delaying gastric emptying slows down the uptake of sugars into the bloodstream, and that's good for diabetics. And the fact that people are not so hungry and they're a bit nauseous, it's great for weight loss because they don't need as much. So it's part of the way they work, part of their mechanism. So during those early stages, it seems to be that the gastric emptying is mostly delayed, and there seems to be some degree of tachyphylaxis as time goes by. So in 2023, both societies, the ASA and the CAS, came up with some little bit loose guidance. They said these because obviously there wasn't much data, so there was nothing very concrete on which to base very strong recommendations. So they said these are guidances, but you have to they're recommendations, but you have to assess your own situation. Each institution come up with their own guidelines, but more or less they both said that you should consider stopping these medications for a period of time. Nobody knew exactly what period of time is safe enough. In the ASA recommended holding the drug for a week, but we know that to actually really clear these drugs from your system, you need way more than a week because, for example, for semaglutide, the half-life of semaglutide is 1 week. So normally to clear a drug in terms of its effect, you need about 3 half-lives. So you would need 3 weeks to stop the drug to really stop the effect. However, that is not a small thing to do for a diabetic patient that has perhaps their blood sugars reasonably well controlled while on this drug. Stopping it for 3 weeks may have a lot of consequences in terms of poor blood sugar control, which is also very important for these patients. And so the CAS also said we should consider every patient potentially as a full stomach, despite the fact that they have fasting. We should consider extending the period of fasting, perhaps doing a fluid diet pre-op, avoiding deep sedation or general anesthesia if possible. If GA needs to be done, we need to do rapid sequence pretty much for everyone, consider them a full stomach. Or both societies said, consider using gastric ultrasound at the bedside to help guide your management. Gastric ultrasound can help you decide, is the stomach full or empty? Now, this was last year, 2023. You may be aware that just last week, the American Society of Anesthesiologists came up with new guidance on this issue. They got together with a number of other societies that are interested in the topic. They came up with a multi-society paper that was, very general in terms of the recommendations. And then the ASA published this paper specifically for anesthesiologists in what to do about the perioperative management of patients taking GLP-1 receptor agonists. So these next 2 slides are very busy and they don't look pretty. I apologize because I just copy and pasted from the article itself, so I haven't had the chance to make them look pretty, but this is what their guidelines say roughly. So preoperatively, they actually recommend that the GLP-1 agonist in most cases should be continued. They no longer recommend stopping these drugs. They recommend you continue them. And what they do recommend is highlighted here in yellow is that patients should be counseled to have clear fluid diet for 24 hours. So for the day before the operation, they should be just consuming clear fluids, no solids whatsoever, no thick fluids like smoothies or anything like that, just clear fluids. And then for low carbohydrate clear fluids, they should abstain for the last 4 hours. So instead of 2, which is the normal recommendation for most people, they said don't have anything whatsoever for 4 hours and clear fluids only for 24 hours prior to surgery. And try not to stop the medication. They say only in cases in which patients are poorly tolerating their GLP-1 agonist. Sorry, I'm going to get the laser pointer here. So only in cases in which patients are poorly tolerating the drug with nausea, with vomiting, maybe you may consider stopping the medication, but you need to partner with the prescriber, perhaps change their diet, de-escalate the dosing, and if the symptoms are not resolved, consider stopping the medication or delaying the procedure. But they're really de-emphasizing these. Now, what to do on the day of surgery? Well, when you meet the patient on the day of surgery for the first time, they say, if the patient is completely asymptomatic from a GI point of view, and they have appropriately fasting, which includes 24 hours of clear fluids, you can be pretty confident that they are going to be safe, that the stomach is empty, and you can proceed as usual. However, if the patient has not followed these 24 hours of clear fluid, or they're symptomatic with nausea, with vomiting, well, you should consider doing gastric ultrasound to help you decide, is the stomach empty or is the stomach full? And if you have no gastric ultrasound for some reason, then you should either delay the elective procedure and reevaluate so that the patient has the opportunity to properly fast with clear fluids for 24 hours, or you should treat every single patient as a full stomach with full stomach precautions. So this is the new recommendation, fresh from the oven just last week from the ASA. So how do we use gastric ultrasound? This talk is a little bit about this area, and I have been doing research on gastric ultrasound since 2008, well before this was fashionable. And I believe, just like any other organ where we use ultrasound, point of care ultrasound has 4 main steps. First of all, you need to have an indication. In this case, is whether the patients are taking GLP-1 agonist or not, and what should we do with them. And then you need to know how to acquire the images. Once you acquire the proper images and that are of good quality, you need to interpret them. What do we call an empty stomach versus a full stomach with ultrasound? How do we define that? And based on that interpretation, it's gonna help you take some medical decisions. So let's start with the case. This is a real case. I had a diabetic patient with a BMI of 37 who was on semaglutide. She had started in the last 3-4 months, and she had her last dose 3 days ago. She had not been seen in the clinic, so she had fasted as per the usual fasting guidelines of the hospital. And she was coming for an elective procedure, an injection of bleomycin for a facial veno-venous malformation. This is typically a short procedure, 20 minutes, half an hour. And normally we would do this procedure under deep sedation, but with no airway device. So the indication in this case was, does she have a full or an empty stomach? And as we discuss this, I would like you to think yourself, what do you think about this lady? Would you consider her a full stomach or an empty stomach? And what are we going to do about this case? Should we reschedule? Obviously she hadn't done any special fasting and she hadn't stopped the drug. Does she need to be intubated and do a rapid sequence induction? That's an option as well. But of course, it's escalating care, and intubating someone doing a rapid sequence is not without its potential problems sometimes. So that's the question. What should we do? So based on that, we did a gastric ultrasound, and we found, this is a typical image that we're looking for. This is the liver here towards the head of the patient. This is towards the feet of the patient. And then the antrum of the stomach is the first hollow viscous distal to the liver. You can see in this case is very small. It's about 2 by 2 centimeters. It's essentially completely empty. All we can see here is the gastric wall, the different layers, including the muscularis propria, which is the most prominent. The antrum is anterior to the pancreas and anterior to the aorta and the spine. So this is the view that we're looking for. And in this case, the antrum was completely empty. Now, we did this exam in 2 patient positions, and this is very important: supine and right lateral decubitus position. The supine position is actually the least sensitive to identify gastric content because the fundus is deeper than the antrum in the supine position, and it can be hiding a certain amount of food or liquid. You might not see it. So whenever you find an empty antrum in the supine position, you need to place the patient ideally in the right lateral decubitus. And in this case, it was completely empty in both. It looked completely empty in both positions, in which case you can be pretty confident that the stomach is empty. This is what we call a grade 0 antrum. The area of the antrum was 6 centimeters square. We're going to look at that in a few moments, and that corresponds with negligible volume. So based on those findings, we concluded that she had an empty stomach, and we treated her as such, despite the concerning history, we were quite confident that she had an empty stomach. She had deep sedation without an airway device. She had a safe anesthetic, and we avoided an unnecessary cancellation or an unnecessary general anesthesia and intubation in this particular case. So this is how we use gastric ultrasound at the bedside. So when we're doing gastric ultrasound, really the portion, we don't see the entire stomach. It's quite consistent to find one part of the stomach that we can consistently assess, and this is the antrum, the most distal part of the stomach, as you can see here marked with the blue circle. It's the most distal part, it's roughly cylindrical, and it's quite consistently located anterior to the aorta and anterior to the spine, deep to the liver. So this is the area we're looking for. The important thing we need to know, and all of this is based in multiple studies, what we can see in the antrum is a good representation of the entire stomach, because of course we are not only interested in antral content, we want to assess the content of the entire stomach, and the antrum tells us that picture. So this is again the view we're looking for. It's really one plane of imaging. We always want to see the liver, and that's very important, because if you don't see the liver, you may be too low in the abdomen. You may be looking at a structure that looks like the stomach, but it's something else. You could be looking at the colon. You could be looking at small bowel. But if you find the edge of the liver, the first hollow viscous is typically the antrum, like you see here. In this case, there's a little bit of clear fluid, anterior to the pancreas, again, anterior to the aorta. Very important to remember to place the patient in the right lateral decubitus. If the supine position looks empty, don't trust it. Put the patient in the right lateral decubitus. Now, if the supine position shows you a very distended antrum with lots of content, that's your answer. But if it looks small, put them in the right lateral decubitus. You'll be surprised the difference. So again, this is the same video. What does empty look like? A completely empty antrum, a completely empty stomach has an antrum that is small, about 2 by 2 centimeters, that some people call these like a bullseye appearance with multiple layers and essentially no content. This is what we call a completely empty stomach with a gray zero antrum. After a cup of tea or a glass of water, you're going to see something like this, an antrum that is a little bit distended with clear fluid content. That's anechoic. And after a solid meal or thick fluid, such as a smoothie, milk, yogurt, these kind of things, you might get this picture. An antrum that is distended, definitely bigger than 2 by 2 centimeters, with a hyperechoic content. And the solid is typically mixed with air, so it creates this wall of artifact behind the antrum. You cannot properly see the aorta, you cannot properly see the pancreas, you cannot properly see the spine. This is very typical of air mixed with solid content. So this is the first step when we're doing gastric ultrasound. Identify the antrum is number one. And the second step is to identify the type of content. And we should never skip this step. So what is the type of content? Nothing, clear fluid, or solid? 3 options. If you have nothing in either patient position, that's an empty stomach. This has been proven over and over again. It's very accurate that the stomach is really empty if you have nothing in either position. If you have solid content in any position, then by definition, that's a full stomach. It's not really an empty stomach. Now, if you see clear fluid, we need to do a third step, which is consider how much clear fluid. Why? Because 50% of all fasting people have a normal amount of clear fluid in the stomach, which are fasting secretions. So can we measure volume? How do we know if this is too much for fasting? So there's two ways. The most accurate way is to do a volume estimate, and we've done these studies with peer review grants from the American Society of Anesthesiologists and APSF, and later on supported by the CAS as well. So we can estimate gastric volume quite accurately by measuring the area of the antrum. We have determined that the area of the antrum correlates well with the volume of fluid in the entire organ. And if we measure the area in the right lateral decubitus between contractions at the level of the aorta, we can have a good idea of the volume in the stomach. Now, this is a study we did supported by the CAS as well with looking at these were patients that were having gastroscopy. So we gave them at random a volume of apple juice to drink, and then we did a blinded gastric ultrasound, and immediately afterwards a gastroscopy, and we suctioned the entire content. We studied volumes from 0 to 500 milliliters, and we could see, based on these data, that the cross-sectional area of the antrum in the x-axis here in centimeters square correlates linearly with the volume in the entire stomach in a linear manner. And the formula at the top sort of describes that relationship between the antral area and the volume. Now, obviously, nobody's going to be applying a formula at the bedside and spending a lot of time doing these things because we need to make fast decisions in anesthesia. So that formula can be expressed in the form of a table. But I'm showing you these things so that we understand where all of this is coming from. So we can express that formula in the form of a table. And as we can see here, the age at the top and the cross-sectional area in the first column. If you know those two things, the age and the cross-sectional area, you can have a pretty accurate idea of the volume in the entire stomach. And the volumes in blue here at the top, up to about 100 milliliters, up to about 1.5 milliliters per kilo, it's completely normal in fasting people. But when you have bigger volumes at that, 200, 300 milliliters, that is not common at all in the fasting population. And as you can see here with this gold bar that crosses number 10 here, pretty much, less than 10 centimeters of cross-sectional area with clear fluid alone, these could be baseline gastric secretions that we don't need to worry about. But the bigger the antrum, when we're talking about 15 centimeters, 20 centimeters, that is really in excess of what you would see in a healthy fasting person. So that's how we use this information. Everything that I'm discussing today has been published, by the way. So it's not, ongoing research or preliminary. This has been published and confirmed by external validation multiple times. So this is one study that we did a few years ago in which we looked at 200 fasting patients with low aspiration risk. And what we found is that the majority of fasting patients have either a grade 0 antrum or a grade 1 antrum. You know what a grade 0 antrum is when it looks completely empty in the supine and right lateral decubitus position. We define a grade 1 antrum when we see some clear fluid only in the right lateral decubitus position, nothing in supine. That's what we call a grade 1 antrum. And grade 1 antrum is very common in fasting people, and it correlates with very low volumes. In this particular series, it was 0.2 plus minus 0.5 milliliters per kilo, well within the range of normal. We had a small proportion of patients, about 3% of patients in this series, that had higher than expected volume, and they had a grade 2 antrum. So you could see the fluid even in the supine position. You could see the antrum was a little distended and there was fluid in there. So this is what we call a grade 2 antrum. It correlated with much higher volumes of gastric content. In this particular case was about 3 milliliters per kilo on average. Really outliers, not common at all in the fasting population. So this entire thing kind of closes the loop and completes the picture of how we interpret gastric ultrasound at the bedside. If you have nothing at all, you can be pretty confident that's an empty stomach. If you see solid in the stomach, we consider that a positive for a full stomach. And if you have clear fluid, then we ask ourselves, is this a grade 0, grade 1 antrum, or is this a grade 2 antrum? And what is the volume? Anything less than 10 centimeters square, less than 1.5 mils per kilo, or about 100 mils for your average adult, I'm not worried. That's consistent with the fasting state. We put these patients off to sleep every day without thinking twice, and these patients have a very low risk. However, if you have a grade 2 antrum, more than 10 centimeters square or more than 1.5 mils per kilo, I worry about these people because this is not common at all in the fasting population. In fact, in that series of 200 patients, we had only one regurgitation of significant gastric content, and that happened in the grade 2 group. So, one case doesn't prove anything, but we know that grade 2 is very rare, fairly rare in the fasting population. So we consider this a full stomach as well. We recently, this year, published a meta-analysis looking at many studies that we have done with gastric ultrasound of our sort of research network, 1,200 patients. And this is the data basis of that number I was mentioning, the 10 centimeters square. We looked at 1,200 patients. 260 of them were obese, 217 were elective fasting pregnant women for elective C-section. And then the remaining ones were adults that were not obese or not pregnant. And when you look at the 95th percentile of the cross-sectional area of the antrum was 9.9 centimeters. So on average, the average number or the median number was about 4.7 centimeters square, but that's just the median. There's a lot of people that have higher bigger antrums than that, and that's normal. Again, all these people were fasting and they were otherwise quite healthy. And in our multiple studies that we have done, we actually found that obese people taken as a whole and elective pregnant women that are healthy don't have bigger antrums or bigger amount of fluid than non-obese or non-pregnant people. They're very similar. And again, the 95th percentile of the area is just around 10 centimeters. This is from the same study, a graph to show grade 0 antrums. These are all fasting people. The majority have a grade 0, grade 1 antrum. There's a lot of overlap in the cross-sectional area in terms of, this population, grade 0, grade 1 antrum. However, grade 2 seem to be a little bit of outliers with bigger antrums. As you can see here, the grade 2, the group of patients with grade 2 antrums had a mean area that was higher than 10, and a lot of them had cross-sectional areas that were bigger than 10. So we use that number as a bit of a threshold. Every threshold is conventional, and every number can be questioned, of course. It's not a perfect threshold, but when we consider everything together, a grade 2 antrum, or an area bigger than 10, or a volume greater than 1.5 mils per kilo, we worry about that. I know some of you practice in pediatrics. There are some studies in pediatrics, not many. This is one of them. It was actually done in Calgary by one of our colleagues there, Adam Spencer. I helped them remotely, but they did the study in children. The issue with children is that when they tried to do these models, so they also have a formula and a model, but the volume model has many limitations because it's just too long to explain all the details, but basically the main reason was when they studied these, they couldn't feed their children. They couldn't give them anything to drink, obviously, before a general anesthesia. They were having gastroscopy under general anesthesia. It wouldn't be ethical and it would be risky to do that. So the model that they came up with, it's only based on baseline fasting volume. So it has limited application. But what is very similar in children compared to adults is the grading system. So this grade 0, grade 1, the distribution was not too different from adults. So in fasting children, the vast majority had either a grade 0 or grade 1 antrum with low volumes, and they had about a 9% of their children. These were children having gastroscopies, or perhaps there was a reason they were having the gastroscopy. Some of them had some GI issues, and about 9% of them had a grade 2 antrum and with volumes that were on average 1.5 mils per kilo. So the grading system works very similarly in children, in pregnant women, in obese compared to adults. The first fasting guidelines in the world to incorporate gastric ultrasound were in children. This is from the European Society of Anesthesiologists, the preoperative fasting guidelines published a couple of years ago in 2022. They recommend that if children are coming for elective surgery, but they have unclear fasting, you don't know if they ate or they didn't eat, or if they're coming for emergency surgery, you should consider doing gastric ultrasound. And even though the cross-sectional area is a surrogate of gastric volume, in children, they recommend that the grading system 0, 1, 2 should be preferred over volume calculations. And I completely agree, because as we discussed, the volume model in children is not as accurate probably as in adults, but the grading system works just as well. And of course, the type of content is very important. So how accurate is this? So this is a study we did in healthy fasting volunteers. Half of them, we kept them fasting. Half of them, we fed them. And we had two blinded anesthesiologists do gastric ultrasound and decide on a binary manner, do we have an empty stomach or do we have a full stomach, based on the definitions that we discussed before. So empty stomach, we consider nothing, a grade 0, or a grade 1 antrum with less than 1.5 mils per kilo. Full stomach is solid, or a grade 2 antrum, or more than 1.5 mils per kilo. So that was the binary definition. And then we looked at the sensitivity, specificity of all of these and positive and negative predictive values. So if we use a Fagan algorithm starting with a 50% pretest probability, if you get a positive result for full stomach, in this particular study, the chances that the person actually had a full stomach was 98%. And if you had a negative scan for a full stomach, the chances that they had a full stomach was less than 0.1%. So very accurate in this setting. So I'm going to give another clinical example, and then we're going to wrap up. And I think this is an interesting example, because gastric ultrasound doesn't only apply to the GLP-1 situation. It applies to any clinical scenario where gastric content is uncertain. So we had this 82-year-old gentleman last year who had a fall. He fractured his C-spine at the C5 level. He came on a hard collar. It was a Saturday night for an urgent C3 to C7 fusion. Our a priori plan, before we saw the gentleman, I was planning to do an asleep fiber optic intubation. However, when I saw this gentleman in the holding area, pre-op area, he was nauseous. He was quite nauseous. And he had fasted properly for more than 12 hours. He was not taking any fancy medications, no GLP-1. This was before the area of GLP-1s. He was not diabetic. He was not obese. And he didn't have any other risk factors for aspiration. But he was nauseous, and this really bothered me. I wasn't sure what I was dealing with. So The question is always the same. Is the stomach full or empty? That's the question, the indication for doing a gastric ultrasound. And how should we manage the airway in this case? Is an asleep fiber optic intubation truly safe in this gentleman, or should we intubate him awake, or should we do something else? So we did gastric ultrasound, and this was his antrum, massively dilated with clear fluid. He had a grade 2 antrum, and it looked like this in both positions, supine and right lateral. The area was 37 centimeters square, way above the 10 number that we use as a threshold, and the estimated volume was more than 400 milliliters. The saving grace in this case is that the content was exclusively clear fluid. So we decided to put an nasogastric tube and suction before induction. And this is what we suctioned from the stomach. This is the canister from that patient, 450 milliliters, as expected, more than 400. We repeated the gastric scan, and now we had a grade 0 antrum, completely empty, with an area of 5 centimeters square and an estimated volume of 0 to 10. So following all of this, we could do our asleep fiber optic intubation as originally planned, which was completely uneventful, and he could have his surgery quite safely. So it helped us guide management in this patient. We knew exactly what we were dealing with. We knew we had clear fluid. There was definitely a full stomach with 400 milliliters of clear fluid or more. And that prompted us to place an NG tube awake, which I wouldn't have done otherwise, just to see what was there. If this had been solid, I wouldn't have put an NG tube because it wouldn't have come out if it was solid. We would have done something completely different. So after we suctioned from the NG tube, we confirmed that the stomach was empty prior to induction, and it allowed us to proceed in a safe and comfortable manner for all. Now, gastric ultrasound has limitations. 2 to 5% of cases, it may be inconclusive. You may not be able to find the antrum really well, and sometimes it's difficult, particularly if it's empty. If the patient has had prior gastric surgery, such as gastric banding, gastric bypass, partial gastrectomy, the volume model may not be accurate in those situations. So these are definitely limitations of gastric POCUS. So in summary, we talked about point of care gastric ultrasound. What are the indications for it? We touch bases, especially on the issue of GLP-1 agonists, but this is a tool that goes well beyond GLP-1 agonist, and it is helpful in any situation in which you don't know clinically if you're dealing with a full stomach or an empty stomach. It helps us make medical decisions, and it's recently been incorporated into fasting guidelines for children in Europe, for example, and the ASA and CAS recommendations for the GLP-1 agonist. We touched on the limitations. So I just want to leave you with a thought, something that I really makes me think about our journey in gastric ultrasound in the last 15 plus years. And it's something that Arthur C. Clarke said and wrote. He was a scientist in his own right, and he was the author of 2001 Space Odyssey, both the novel and the script for the movie. And he said that every new idea or revolutionary idea, he said, whether it's in the arts, in politics, or in science, it seems to evoke 3 stages of reaction. The first stage is people are going to say, it's completely impossible. Don't waste my time. After a while, when it's clear that it's possible, people say, well, it's possible, but it's not worth doing. And we've heard it all. It takes too long. You need to learn something new. It's expensive. Do you really have an ultrasound or not? There's all the buts. And then after a while, when something is very well established, people say, I said it was a good idea all along. And I think we're reaching that stage with gastric ultrasound, but it takes time. But if something is clearly helpful, don't give up just because people say it's impossible at the beginning.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.